Good afternoon, everyone. Thank you for sticking this out with us. Can't believe you're here. So my name is Dr. Adesina, for those of you that already know me.
I'm Dr. M. Tyson Pillow.
So today we are going to be giving a talk about bridging the communication gap, providing a framework for training and utilization of medical interpretation services. By show of hands, how many people have heard the story of Willie Ramirez? Okay, great opportunity to share. So, Willie Ramirez in 1980 was a 18-year-old male that was taken to a local emergency department in Florida. He was taken there for altered mental status, and his family was Cuban and they only spoke Spanish. So the doctor communicated with them using a medical staff who was bilingual. And the mom communicated that he was presenting with the altered status, mental status, due to intoxicado, and he had eaten a hamburger the day before, and they thought that was why. And this was translated to the family as intoxicated, and he was diagnosed with acute intoxication. In Cuban Spanish, intoxicado means something you ate or ingested. It wasn't until 36 hours later in the ICU that they noticed a neurologic decline. At that time, they proceeded to obtain imaging, and they saw he had an intracerebral hemorrhage. They rushed into the OR, but by then it was too late. They tried to stop the bleed, but by then he was a quadriplegic. Willie Ramirez was an 18-year-old who never engaged in drugs. He was a baseball player. This mistake with medical interpretation cost the hospital $17 million, and it caused this young man a reversible cause of quadriplegia. So he wrote a memoir that was sold on Amazon, and I found this comment by one of the reviewers, and it stood out to me. I like to highlight the title, By No Means an Isolated Case, and I took this quote verbatim. It says, the medical community needs to stop taking linguistic issues so lightly. Just because someone speaks Spanish does not mean they are qualified to interpret for others. And I think this statement summarizes the basis for our talk today, and it sheds light on the weaknesses in our system when it comes to using linguistic services.
So very briefly, the primary goal is to talk about a framework that our UME team, led by Dr. Adesina, has worked on. We're going to start by discussing the importance of communication when caring for limited English proficiency patients. And obviously, we're preaching to the choir, plus one, everyone else we work with, so thank you for joining us, Arlone. But also discuss the 3 pitfalls common among trainees and really talk about the curricular framework and a little bit of some of the good work that we've been doing to kind of explore this. This is just a graphic to kind of take in the number of immigrants in millions. So you see, if you're looking at, when we kind of hit a low around 1960, 1970, around 9.6 million, to projections up to the 69 millions or so as far as 2060. So not only is this something we're seeing, but it will continue to grow. So it's part of what we do, part of who we take care of, especially being in certain places, right? So, for example, I grew up in St. Louis, Missouri. Interestingly, it has the largest Bosnian population outside of Bosnia itself. Right? So this is going to be something that's not just Spanish or Vietnamese, but kind of can be anywhere that we're practicing. And then thinking about this, thinking about the number of people that speak a language other than English at home, we see a large portion, again, the numbers are in the millions and just going up and up, reflecting that increased immigrant population as well. I wanted to pay particular attention to the speaks English less than very well, right? I think a lot of this bias that plays in comes when a patient presents. They want to please you, right? They want to get along with their doctor. So when you say things like, hey, do you understand? And you nod your head, right? Then they're nodding their head. they're trying to make the best of what they can in what might be broken English. And we take that as a positive. Sometimes getting an interpreter can be tedious, right? Sometimes you just miss them because you had to go run a code up front, or the med student just used them for 20 or 30 minutes, now you got to call them back. There are all these factors that kind of affect that, but it's very, very important to realize that we absolutely have a lot of patients who will say that they speak English when asked, but actually don't speak very well as far as understanding. I think another complicating factor is just medical jargon, right? And just understanding the ability to speak versus the ability to understand exactly what's going on medically for them. Medical interpretation in the law. So this is actually very, very interesting because, just very briefly, we know that we should be doing this. We're actually mandated by law to do this. We're required to do this by the Title VI of the Civil Rights Act and the Affordable Care Act. It's actually mandated to use a qualified medical interpreter, right? The example I like to give is this qualified medical interpreter and I've definitely seen this, when you have someone coming in complaining of vaginal bleeding, for example, and you try to get their 12-year-old son to translate the problems that mom's having or grandma's having or otherwise, right? So it really, really is important, not just for the medical care, but also we know that this is mandated. We know this is something we should be doing every time. We also know that there's huge impact. Again, preaching to the choir, we don't have to talk too much about this, but we know that there's huge impact in their care, right? We know that our patients go away and they come to us, they come back to us, maybe come revisit the ED. They say nothing was done for me, right? And you look in the chart, they had a cath. They were thinking about going to cabbage, but there was some complication. So they decided to do this management instead. So our patients don't understand. So there's deferment in the needed medical care. There's reports of poor health. They leave AMA. They miss follow-up appointments and really become victims of medical error, as we saw with our first case. So, quote by Maya Angelou, I like to think of these equity issues, these things we need to think about to improve our care. Do the best you can until you know better. Then when you know better, do better, right? So we are getting to know a little bit better today, so that goal is going to be thinking about that framework we're going to propose and how to do better going back. Okay? Lots of barriers that we recognize as well to utilization of a professional interpreter. One that we like to point out, there's a lack of reimbursement for language access services. This is actually something that Dr. Adesina taught me very recently, that there's very little to no reimbursement for this. So I'll ask very briefly, do you all happen to know, these are based on numbers that are about 10 years old now, how much would we have to increase the medical bill for all patients to provide adequate language services for any patient? How much would we have to increase the medical bill for all patients to make sure we provide adequate medical language services for any patient? Any takers? I got a 5. $2? 30 cents. 30 cents. I like it. You guys are informed. You're educated, so you're giving me numbers. Usually we go present this. It's like 100, 200, 1,000, $4.04 to the bill. And we can actually satisfy this mandate and make these language services available, right? So it should be incredibly frustrating that we are not doing our job here. Right?
Thank you, Dr. Pillow. Now that Dr. Pillow has kind of established why this is such a big deal, we're going to discuss 3 common pitfalls that trainees, when using medical interpretation services. And this is to the crowd. What are some common pitfalls that you think occur when using a medical interpretation services?
Like not speaking to the patient, like speaking to the interpreter but not the patient.
Mm-hmm. Same one? Okay. Okay. Yes, there are many pitfalls that we observe in a clinical setting, but I can say one of the most common one is using ad hoc interpreter, not using a professional interpreter, a qualified medical interpreter, because we don't realize the risk that we're putting our patients at. So I think ad hoc interpreter is one of the most common and amongst many. Now, with ad hoc interpreter, the error rate is more than 50% when we use a family member, when we use an untrained medical staff, as opposed to when we use a qualified interpreter, that's 2%. Now, all of us, as I believe we're all providers in this room, we all have an acceptable miss rate for diagnosis like PE or subarachnoid hemorrhage. What is your acceptable error rate when communicating with your patient? Is it 50%? Is it 20%? So think about that number. And this is what happened when you use ad hoc interpreter. It's prone to more errors, and like Dr. Pillow highlighted, if you're taking a history from a mom, maybe sexual history, and the child is interpreting, what kind of information do you expect to get? Or if you're getting information from someone, however, the person that's interpreting on their behalf is the perpetrator or the abuser, how do you expect to get to the kind of information you need? As well as other interpretation errors, you know, and also confidentiality issue. But when you use a qualified interpreter, you reduce those errors. It's been shown that they're less likely to have prolonged hospital stay, 30-day readmission, and patient satisfaction also goes up. The second one is just an umbrella, under this umbrella of not using best practices, like was alluded to, kind of speaking to, instead of speaking directly to the patient, things like speaking to the interpreter. So how often have we heard this? Interpreter, can you please ask the patient if she's having any pain, or can you ask the patient to show me where the pain is? You should be talking directly to the patient and not to the interpreter. The interpreter should be interpreting verbatim, or using long drawn out sentences where when the interpreter now interprets, it's just a really short interpretation, which tells you that the interpreter just summarized what you said, and using medical jargon, and a list of other things. So these are the best techniques that have been identified in literature as best practice. Are we following these? The third one, before I go into the third one, I want to highlight this quote. The single biggest problem in communication is the illusion that it has taken place. Even with an interpreter, sometimes when we're communicating with patients, sometimes we assume that they understand what we said. Like the example that Dr. Pillow gave, for example. So you have a patient, and we've all been in this situation, that comes in for a chief complaint. And you said, okay, I've been here before. You said, okay, what was done? What was the diagnosis? Oh, they didn't tell me anything. So did they do any workup? No workup was done. And you look and you find labs, imaging, even a consult, a follow-up, and documentation that communication actually took place. So this goes for every patient and not just someone with language barrier. You need to check for patient understanding. So at the end of the encounter, say, can you explain back to me what the instructions are? Or can you explain what I just told you? Or have them teach back whatever you taught. And then ask them, what are your questions? Not do you have questions, but what are your questions? So now that we've talked about some of the pitfalls, the three common, we're going to talk about a curricular framework that we use to kind of come up with a training module for our learners to try to help them learn how to utilize a medical interpreter. So at our shop, we have a large immigrant population. I would say it's more than 50%. And in a given shift, you're using an interpreter more than you're not using an interpreter. So it was identified by school leadership that, you know what, we need to come up with something where a curriculum where we're formally training our learners how to optimize and use the interpreter in a way where they're able to effectively communicate with patients with a language barrier. So I'm going to talk about the framework, but before that, I'm going to talk about our approach. How did we arrive at this framework, what the framework included, and what we did, and briefly go over some preliminary results that we had. So we went to, of course, the famous Kern's 6-step model for curriculum development, and we identified and defined the scope of the problem. So what was the problem? Well, our learners were ill-prepared to use their interpreter due to lack of training. Currently, they were getting an hour-long lecture on the topic, and which some of them did not recall, and it did not translate to skill. So we went to literature, of course, right? And I'm going to highlight some of the studies that we used to come up with our framework. And it's not to criticize the studies, but it's just to highlight how we picked out what has been done, what worked, and what didn't work. So the study on the left, how we developed an effective E-module, they used the E-module to demonstrate and train students how to use an interpreter, and they used a pre and post test that checked for their self-efficacy and it checked knowledge base. This study on the right, workshop, it was an interactive workshop, and it was a multidisciplinary team including professional interpreter, faculty, and students. And this workshop was designed to train them how to use an interpreter, and they test, at the end, they assessed for confidence and comfort level, which we know does not translate to skill. So after doing a thorough literature search, found that the common teaching method and modalities consisted of one or a combination of these. So didactic, video demonstration, case-based learning, simulation, and e-modules. And their assessments always fell under one of these categories. So subjective things like confidence, comfort, perception, and then objective was like knowledge-based question. So I kept looking. I wanted to see if there was a more comprehensive curriculum, and I found this study. This was a comprehensive curriculum. It was a 3-year longitudinal experience where they were teaching students to use the interpreter, and it was a multimodal approach. They had case-based, they had didactics, they had other sorts of, they had video demonstration, and at the end of it, they assessed how well the curriculum performed. And this is what they used for assessment. View and discuss a video outlining the principles of using an untrained interpreter, and also practice the skill of taking a history using an untrained interpreter. And we hope that the goal of this is actually to highlight the limitations of using an untrained interpreter and the adverse effect it can actually have on patient outcome. So we took everything from that, and then we said, okay, so what's an effective way to teach this kind of skill? So I found a systematic review, which said, okay, they looked at a bunch of articles, they looked at a bunch of studies, and they said, what are the most effective ways to teach this communication? And they came up with this, and they said the top 3, practice the skill. So tapping into that experiential learning theory where they are learning by doing. This is a skill, and unless you practice it, you probably can't perfect it. And learner-centered, sort of garnering your learner's experience, past exposure, and focusing the experience based on that. And they recommended that it should be at least a day. So we used that to create our framework, which was learner-centered. We talked to our learners, kind of got a quick overview of where they were currently, their previous exposure to interpretation training, and what their clinical experience looked like. And then we used experiential learning theory to kind of come up with an interactive curriculum where they have a chance to learn the skill by actually performing the skill in a controlled setting. And then objective measures were as such as well, also testing the ability to use the skill. And this is what the approach we took. Didactic, we had video demonstrations, case-based discussions, and skill testing where they used standardized patients to demonstrate this skill. So they had to call into a language access hotline and using that to communicate with an SP patient and take a history. So to check how well the curriculum worked, we use the faculty observer rater scale. This is a validated scale that has been created by Lee et al., and it tests for how well you are able to use the interpreter using best practices. It's on a Likert scale. So we tested the ability before and after, and this is what our results show. So before the curriculum, before the intervention, they scored somewhere between the range of 33 to 37, and after, they scored between 47 to 50, 52, 53. Our goal was to have a 10% increase in the score, and that would be considered a successful curriculum. However, we were able to appreciate as much as a 35% increase. And I think the point here is that to hone in that to teach a communication skill such as using a language interpreter, you have to learn by doing, and you have to incorporate that skill portion. And in summary, we've highlighted the importance of using a medical interpreter in the ED, and especially with patients with limited English proficiency, although you feel like it's taking up time, but in the long run, it's going to save lives. So always remember that. And the common pitfalls can be avoided with adequate training. And any training or communication modality, it has to incorporate the skills portion and the learning by doing. And that is pretty much the whole point of this. Thank you. Do you have any questions?
How is this research supported by the medical school, and is it going to be included in their mandatory training? And at what stage are they taught or given
There's a microphone. So the school is going through curricular reform. I think we're at the stage where we're figuring out these things are important because obviously you all know most of it was the Krebs cycle and how do you what's the most common cause of XYZ. So we're finding out it's more and more important to be threaded throughout. I think the school has done a great job in looking at a lot of issues like this. Accessibility, equity, inclusion type issues. We are just getting to the point where, and actually this was supported, Dr. Adesina was able to secure 2 grants, one departmental, but then actually one through the school to develop this. So I think this is something we're actively looking at and figuring out where it fits. Because that transition, I mean, the challenge should also be at the residency level, right? We can look at ourselves first and say, hey, are we making sure this is part of what you all do and how you all do it? Because you all deal with this every day. So challenge received, and it's just a matter of making sure we have a big enough voice and maybe even looking at it in more systematic ways to get the data to say, yes, we need more significant change faster, right? And of course, as we just kind of took a look at, the actual services are only about $4 each, as it were. So also something we can push on the institution level. The institution did implement, although it kind of, I think the system's still in place, but the institution implemented, our own institution, Harris Health implemented a rule that to be able to translate, you had to pass an exam, a 2-part exam. There was a big wave of training. I don't think that system's policed, unfortunately, but at the same time, they have pushed for that.
But the skill portion only tested for phone because we found that phone was the most easily accessible for students and for all learners on all levels. I think in our emergency department, we're very fortunate that we have in-person, but that is a finite resource, right? If all your in-persons are tied up, you have phone. So phone is something that we know transcends every department. So the teaching, the didactic included video demonstration on how to use phone, how to use in-person, and what to do if you're using an iPad as well. But testing for those things was just a little more because it's a limited resource, testing for in-person. But, yeah.
The $4 value, is that our hospital value, or that's...
It was an estimate. I'd have to pull up the reference again to be 100% sure, and it is older now. But that's a reference from what the estimates based on Medicare, I think it was, of providing adequate linguistic services as a service with that burden spread out against all people in the system.
So with inflation, it'll be $50 or so?
I cannot confirm nor deny that. Yeah, no comment.
I think that would be a great follow-up study. Yeah, I think it would be great to see if not only does it translate to real life situation, but also did they retain that skill a year later, retention.
I would like to volunteer Dr. Adesina to do that follow-up study.
A great follow-up study.
I have a question that's kind of an option, but do either of you know if these for interpreter services is tied to any of the quality metrics, like decrease length of stay or decrease like return visits?
Yeah, so I mentioned that. So that has been well studied. It's tied to decreased length of stay. It's tied to decreased 30-day rehospitalization rate, and also increased patient satisfaction. So that is known.
However, I don't think it's been picked up as an institution as a target to improve those measures, even though we know there's a linkage there. And then we were able to do two smaller studies in our own patient population. So we do know there's potentially significant differences and a few significant differences from English versus non-English, non-Spanish versus Spanish, as far as when they present in their disease, new diagnosis of cancer, chance of going to surgery, chance of death. And so we have data in our own population that language barrier has significant impact. I don't think it's turned into policies that we are following. I will, not to bash. I honestly believe this. Presenting similar work a few other places and talking to people, we do pretty well at Harris Health. I do believe in really trying to make sure these services are available. Most people don't have 24/7 Spanish interpreters. I say most. Many, many institutions do not have anywhere near the linguistic services that we have. That are available. I think the piece missing is the oversight, as you're alluding to, not even alluding to, as you're pointing to very actively.
Isn't it part of the mandate to have interpreter services?
It is the law, yes, sir.
But still not, but some institutions don't have it.
I cannot comment on
For,
those
I mean,
institutions. They don't use it.
yeah, any federally funded institution is supposed to provide this.
There is a parade.
It was there yesterday.
Have you thought about doing some special cases? Really tricky with interpreter services. Sorry, it's tough this time, so is when you're talking to a patient and then the family member who speaks the language is like, oh no, they didn't interpret correctly, or how do you kind of work through a situation like that, or it's 2 a.m. in the morning and you can't reach the interpreter. You're just like, well, is there being got to also look at those special circumstances as well?
Yes, so I think these recommendations are, obviously you have to take into account the situation in your clinical setting. If it's a non-emergent situation and you can wait for a trained interpreter, please do it. But there will be situations where you'll have to make an exception. I've actually been in one of those situations. I was actually using an iPad interpreter, and a family member was there, and they were interpreting, and the patient was answering the question a little off, and then when I got off, the person said that interpreter was not interpreting it correctly. And I actually took down the ID number, and I called the company, and I informed them. So I made a report that actually, and I realized there was a confusion, so I knew that it was correct. Something was off. In that kind of situation, I know that we have to provide timely care, so we really have to balance that with balance getting the patient timely care with the use of interpreter. If you can wait for interpreter and it's non-emergent, then you want to wait for a qualified interpreter, but you don't want to delay care.
Thank you all very much. Thank you very much.